بسم الله الرحمن الرحيم. السلام عليكم جميعا. مساء الخير. Our step today is a step in anesthesia, pediatric anesthesia. مع أستاذ دكتور سعد مهدي, chairman وألف مبروك of Anesthesia Department, University Hospital, Limerick, Ireland. تفضل حضرتك.
Dr. Randa, thank you very much for inviting me to talk before this prestigious and very hard work pediatric course. I know you for a while, and I know you are interested in educational event and improving the educational career. It is a great honor for me to be here today speaking before you, and today it is a milestone for my career. I am promoted to be the chair of the department of the anesthesia in Limerick. I'm working in Limerick for the last 10 years as a consultant anesthesiologist. I have developed a lot of issues like pre-operative assessment clinic, and a lot of stuff to go, and education courses, teaching, exams. I am member of the College of the Anesthesists in Ireland, and now they call it the College of the Anesthesiologists in Ireland, and I'm examiner as well in the college. However, it is a great honor for me to be between my colleagues and my friend from other specialty like pediatric. Dr. Randa just gave me a choice to take my lecture, and it came to me why pediatric anesthesia is different from other anesthesia. Actually, I put this slide 20 minutes ago. I had a case, 9-month-old, 8.5 kg. She was scheduled for examination under anesthesia for eye refraction. The surgeon was rushing because he wants to do it in between cataract cases or major cases, and just claiming that it will take only 5 minutes. However, a child, 5 minutes, you know already why the children are very important. And any issue when, for example, the crash happened in the airplane, they tell you that between 245 victims, there is 5 children. So the children are extremely important and priority for everything. However, the case takes 5 minutes, but for anesthesia is nothing like 5 minutes, simple anesthesia, even sedation. It takes a lot of priority. So we have to do preparation and to have to anticipate and prepare very well for what's going to happen or might happen. The patient developed laryngospasm after induction, before even the nasal mask to put the nasal mask. And thank God we treated that very carefully. After they finished the procedure, the patient developed laryngospasm after extubation, and we treated that. Examination under anesthesia only took 5 minutes exactly, but saturation dropped to 65%. And all of you know how serious when the saturation drops to 65%, and we talk about that later on. It is a very basic lecture, why pediatric anesthesia is different from the adult. Basically, pediatric anesthesia was solo or was under the umbrella of pediatric or American Academy of Pediatric till 1966, and joined the branch of anesthesiology 1973. It was like a small chapter in the pediatric, any pediatric book. But later on in UK system, Pediatric Anesthesia Society developed in 1986. So it is something came recently and took our intention to give it interest. And there is a claim for emergency codes have been opened and in America, and they found most of the claim are due to respiratory origin. 80% of the cardiopulmonary arrest in pediatric for that claim are due to respiratory distress. In the closed claim between 1990, that closed in 1990, and carried out by AC, American Society of Anesthesiologists, they found that respiratory event was a largest class of injury, more common in children than adults. 19 to 92% of the claim were occurred between 75 and 85, so almost 10 years. Before the continuous pulse oximetry and advanced monitoring or standard monitoring to be as criteria. With continuous oxygen saturation and carbon dioxide monitoring, they found all of this incident dropped after 1990, because the first pulse oximetry came to Alexandria University Hospital was in 1994. Before that, you don't find any monitor except the ECG and the non-invasive blood pressure, which is now replaced by the automated blood pressure. Just press the button and the machine will check the blood pressure for you. I started in the era when I was the anesthetist during night time. I ventilate the patient with my hand all the night. When I need to check the blood pressure, I go with the sphygmomanometer to check the blood pressure, is the mercury one, and every 15 minutes. So I was replacing somebody or the nurse to ventilate the patient with hand, and I go to check the blood pressure. My hand was on the pulse all the time. But now, thank God, we replaced by standard monitoring and very high tech. That's why when I talk to my junior anesthetist, I told them that you live in the Rolls-Royce era. Why the pediatric anesthesiologist should know more? He should know exactly what you know about the basic stuff of the pediatric patient, like the pediatrician. He should know more about the airway and the respiratory system. He should know a stage of dentation, and we'll know that a little bit in very short while. And he should know about cardiovascular system in full detail, renal system in full detail, hepatic system, glucose metabolism, hematology, temperature control, central nervous system. You should know everything you know, but we don't write, for example, antibiotic for whatever. We see the patient in a snapshot, and during this snapshot, we should know everything about the patient from head to torso, from basic to pathology, from everything about the patient. That's only, you see that we see the patient for the 5 minutes only, or 10 minutes, or 1 hour for the anesthesia, and we should know everything about the patient. So any pediatric anesthesiologist should know about all of these basic stuff. And we spend ages to know those neonatal or definition. Neonates or newborn is a human offspring between 0 and 28 days. And why is it very important to know that? Because we have, for example, the ambulance, and we had one child who was preterm and now is almost 6 weeks, and his weight is, I think, his weight around 5 or 3, 4, it was around 4 kg, and we would like to transfer this patient to another hospital, and the responsible is neonatal ambulance. And the neonatal ambulance says that how old is the patient? The child is 6 weeks, and no, he's not neonate anymore because the neonatal age is 28 days. And we spent in dilemma, we couldn't transfer this patient to the proper transfer. So we should be aware about those classification, like the toddler, which is a child between 1 year and 3 years, preschool between 3 to 5, school age between 6 to 12, and we know the adolescent. And again, why the anesthesia for children is different. Because if you look at the child, you find the head is taking more than 30% of the body. Large occiput, thin, hollow, underdeveloped in the cheek and the mandible, a floppy omega-shaped epiglottis. We'll go through those issues in full detail. Epiglottis, subglottic is narrow, high larynx, large tongue, and narrow nasal nerves. We should be aware, fully aware, no excuse for the anesthesiologist who doesn't know about the basic and advanced physiology and anatomy of the respiratory system and the airway. For the infant, should have the infant have a large head relative to the torso. The tongue is relatively large and contribute to the major airway obstruction during anesthesia. Basically, because the tongue muscles are very floppy and fall backward to occlude the larynx. The larynx is higher and anterior at the level of C3 to C4. An adult, it will between C4 and 5 or 5 and 6. The epiglottis is long and floppy, longer, stiff, and U-shaped. Why like that? You know, what is the effect of that? It flops posteriorly and occlude the larynx, result in hypoxemia and difficult to ventilate the patient. The trachea is short, and the right main bronchus is less angulated than the left bronchus. And what is the effect of that? Because the tube, when it goes into the trachea and you fix the tube around 12 centimeter and 4 centimeter are in the mouth and 8 centimeter in the trachea, you know, if 1 centimeter far in, the tube goes to the right, and the far out, it goes out of the vocal cord. So you have to be in high alert about the intubation of the child. Neonates and infants preferentially breathe through their noses. And you know that very well as a pediatrician, and thank you very much for that. But the problem, as long as we are in recovery, those patients, if they have some secretion, they are easily obstructed and resulted in hypoxemia. The airway is the narrowest at the level of the cricoid in adults, but in children, they are a subglottic stenosis or cricoid cartilage. That's why when you pass the tube from the vocal cord, it doesn't mean that you are able to pass the tube through that. So the cricoid is the narrowest point in the children. Sorry, I said the adult before, but the cricoid is the narrowest point in the children, not the vocal cord. In adult, the narrowest point if the airway is the vocal cord. If you pass the tube from the glottis, it will be passed through the trachea. But for the children, you expect a lot of subglottic stenosis. Although there is ongoing debate about this true or not, but usually we see that a lot in our experience. Why is this important? Why we calculate the tube, and we'll talk about that later on, but usually we prepare one tube larger and one tube smaller than expected, and we test the tube. If there is leak around the tube, we leave it. If we massive leak, we change the bigger size, or if the tube is smaller, if the tube is tight, we take a smaller tube. As we mentioned before, the children are nasal breather. Again, in the airway, infants have a higher respiratory rate. Low functional capacity result in very rapid hypoxemia and increase the work of breathing. So neonates and infants are fatigued faster. Post-operative apnea after anesthesia is very common, particularly in premature infant, particularly if the patient has morphine intraoperatively. Infants have a higher oxygen consumption, yes, 6 ml per kg per minute, we know that. And because they are high metabolic rate. The minute ventilation is more dependent on respiratory rate rather than tidal volume. They are fast breathing. So physiological adaptation is not well developed in younger age group, and the abdominal muscle strength are underdeveloped. They can't have the 6 packs as the boys do it in school age. Sniffing position in adult to make the ventilation easier, which is not helping a lot in pediatric because the epiglottis is long, floppy, and it can drop, including the larynx. Again, in the respiratory system, the ribs and the cartilage are more pliable, very soft. So when the patient takes breathing, the ribs and the cartilage goes down. Chest wall collapse very easy, and with increased negative intrathoracic pressure. That's what exactly happened today with a 9-month-old child. Control of respiration is very poor, and because the whole neurological system is underdeveloped. Prolonged apnea is common after anesthesia. Hypoxemia in adult improve breathing, but for children makes breathing inhibited. And that very schematic shape for the difference between the thyroid and adult, the airway in adult and in infant. And we see here the cricoid cartilage is very narrow in relative to the adult system. And we explained that already. So you see that on the right side, there is a airway of the adult, and the left side, that's the airway of the children. And you see the epiglottis is floppy and long, and you see the opening here is very, very narrow, and you see that eventually that adult, the size of the tube here, we'll talk about the size of the tube later on, and but you see the difference. This one easy intubation, this one is difficult intubation. Again, the narrowest white is the cricoid cartilage, not the vocal cord. Tube may be small enough to pass through the cord, but not the cricoid cartilage. The larynx is the funnel shape, and so secretion accumulates in the retropharyngeal space. Why should we aware about the dentation? Somebody say that why the anesthetist should know that. It's very important to know about this, because sometimes the children coming very happy, I have a loose tooth here, and with intubation or airway devices, this loose tooth can go down or can be taken out and dropped in the mouth or in the airway, so you made a problem for the airway obstruction. So you have to know when those teeth are growing and when they are taken off, not to make any problem. Again, the cardiovascular system is very important. And when you go to the physiology and pharmacology in anesthesia, you find that the respiratory system, cardiovascular system, renal system are taking more than 75% of the physiology. We all know that the cardiac output equal the heart rate to stroke volume. I didn't say anything new with that. But the myocardium in the children are less contractile, stiffer, in neonates, causing the ventricle to be less compliant and less able to generate tension during contraction. This limits the size of the stroke volume, and the cardiac output is only rate dependent. So if you expect that for adult, if the patient is hypotensive, you give 500 ml fluid or 250 ml fluid. You cannot give that in the children because you are calculating the fluid or whatever according to the body weight. The other reason for the cardiovascular system or difference, the sympathetic nervous system is not well developed. So the patient has a very good vagus, but they don't have a very good sympathetic nervous system. So that's why the patient is liable for bradycardia more than tachycardia. Bradycardia result in reduced cardiac output. Vasopressor in pediatric are not the first option to increase the blood pressure. So what is the first option? Is to increase the heart rate and increase the stroke volume. Another issue, I believe you know that more than myself, the beta ductus arteriosus, it can stay, can reopen again within the next 5 years because the pulmonary vasculature react to the rise of the PO2 and the pH, and following the BCO2 at birth, that's why it closed. However, if any change of those during the 5 years, it can be open again. So you have to be aware about that. When you see a child with heart rate of 120, don't panic because that's normal for them. The blood pressure is not hypotensive, around 90 or so. That's normal blood pressure. But for the mean arterial blood pressure is around 85 to 105. So that's the normal figures. But while if you go down to an age, if you go up to age of 16, and you'll find the heart rate is around 80 or even 50. If they are athletic, that's completely normal. This is the same child who was when he or she was newborn around 120. That is correspondent to the age. That's normal parameter. What about the renal system? Renal blood flow and the glomerular filtration rate is low in the first 2 years of life due to high renal vascular resistance. They have lower tubular concentration ability, which result in a higher obligatory fluid loss. About the hepatic system, I know you know those issues, but I'm explaining to you here as anesthetist the role of the anesthesiologist, why he should know all of that. Because if the renal system, I will go back to the renal system, is not fully elucidated. So if you give the patient, the adult patient, 1 liter of fluid, no harm, because the patient kidney is able to excrete the extra amount of fluid. But if you give the child other little bit more fluid than usual, the child will result in congestion because the renal system is not fully developed. About the liver is initially immature with decreased function of the hepatic enzyme. So barbiturate and opioid, for example, have a longer duration of action due to slower metabolism. So morphine is not innocent in the children, and if you give any hypnotic or any sedative or any opioid, you have to be very careful because the blood-brain barrier is not well developed. The brain sensitivity to those opioids is very high, and the metabolic excretion is not well developed. About the glucose metabolism, it's very, very important. And we have a case report in Nelson Island. I will talk to you about that in 1 second. Hypoglycemia is common in stressed neonates, and the glucose level should be monitored regularly. Glucagon stores are located in the liver and the myocardium. Neurological damage may result from hypoglycemia. We all know that. And the hyperglycemia is usually iatrogenic. Why glucose is very important. In Northern Ireland, there was a child who was in the war, and some doctor wrote to him glucose 5% and 20 ml or whatever amount of fluid given per hour. And the next doctor came, continued the same medication like what we do every day. And the patient started to take glucose with no electrolyte for, I think, 1 or 2 days, resulted in brain edema, and the patient died. So now in UK and in our system, if you give the children fluids, you have to monitor the electrolyte every 6 hours at least. If it is stable, might go to 12 hours. But if the patient is in IV fluids continuously, you have to monitor the fluid electrolyte, especially sodium and potassium. So hematology, when the child is delivered, the hemoglobin is around 19.3. Oh my God. And around less than 1 month, hemoglobin is 16.6. And later on, after 6 months, it's 12.5. So that is the hemoglobin, because this one is very important. And that is the hemoglobin, fetal hemoglobin dropped by age and month. So after 6 months, the amount of the fetal hemoglobin is very low. Why is this very important? Because the fetal hemoglobin has a very good affinity to the oxygen and bind to the oxygen very well. So it does not offload the oxygen at the tissue level. Temperature and regulation is extremely important in pediatric anesthesia, and especially in the Western society, because the temperature is very cold. Even in summertime, we have a very low temperature in theater. I know you say that it's very abnormal point to talk about that, especially in the Middle East, the temperature is roasting. But in theater, usually we have air condition or whatever, so the operating room is very cold. Why should we know about regulation, temperature regulation in children? Babies and infants have large surface area to the weight ratio with minimal subcutaneous fat. no shivering till 1 year old. It is normal reactivity or normal reaction to the temperature, low temperature. We shiver, we increase the metabolism, we increase the heat gain in the body. They have poorly developed shivering. They don't shiver very well. They can't sweat properly. They can't have vasoconstrictions. They're always vasodilate. Due to this reason, the heat loss is exaggerated during general anesthetic. Infant and the children may lose up to 2 degrees centigrade during the first hour of anesthesia. That's why if you go to the operating room, if a child coming, we have a heating mattress on the table. We have a bear hugger, like a blanket, a hot blanket, and all fluid are warm fluid. That's why active measures should be taken to prevent hypothermia, especially iatrogenic hypothermia. We have forced air blanket above the patient to technique to actively heat the operating room. We adjust the temperature of the theater as well, and to minimize the heat loss, and warm the fluid to the patient. Central nervous system is very important in many reasons. Number one, the blood-brain barrier is underdeveloped, and the patient is very sensitive to opioid and sedative. So about 150 articles have been published using animal models, from rodent to primate, all kinds of anesthetic, with exception perhaps xenon and to some extent dextromethorphan, have been implicated in neurotoxicity. Neuromuscular junction itself is immature. So when you give the muscle relaxant, you have to be very cautious. So this point is very, very important in children. You find the child coming with his mom and his dad, and they have the fear. The child doesn't have fear much. He doesn't know what's going to happen to him, especially in young children. And the child dad and the mom are absolutely apprehensive. So you have to talk to them very cautiously. You have to be nice to them. You have to be empathetic to them. You have to be very professional to alleviate their anxiety. You have to be sure that you give them the message you want to do. Especially the children are upset from separation from their parent, and the parents themselves are upset to see their children weak or sleep or whatever. And a lot of time you find them crying in the operating room, loading your stress, but you have to be calm enough. Older children and infants up to school age get very upset and stressed by separation from their parent and exposure to unfamiliar environment, like people in theater and wearing different clothes, different environment. It is a challenge to rationalize with the children at this age. Older children and adolescents can get very apprehensive about surgical procedure, especially they are anticipating pain or unknown environment going to happen to them. Older children are very concerned about loss of control, about loss of consciousness. They are talking loudly about their experience, subconscious. All of these are very important. And on top of that, you have to be very professional with the parent and relative. Sorry, I have to go back to the slide again. When you talk to the child, you have to be dealing with the child. You give him the respect. Even you have, that's what I do myself. I go down to the level of the child. I talk to him, I respect the child. I ask him to listen to me, and he listens and to concentrate very well. Even after 2 years, the child is very, very good, and is like the child likes to give him attention. That's his right to give him attention, and they understand. And when you're going to move from the child to the parent, I usually ask permission from the child. I would like to talk to your dad and your mom. Do you have any objection? The child says, yes, I am fine with that. Go ahead. Give him the respect. ask the child permission, give him identity, give him control about his environment, he will give you the trust and lose his fear about the environment. You know, professionalism, even with the children, are very important. So we finished the basic stuff about the physiology and the psychology. We can talk about the pharmacology. And yes, the pharmacology in children is quite different from adults. During the first several months after birth, rapid development and the growth of the organ system take place, altering the factors involved in uptake, distribution, metabolism, elimination of the anesthetic and the other related drugs. So pharmacokinetic and the pharmacodynamic are quite different in children. The extent of the difference among infant and the children and adults in response to the administration of drugs is not just the size of the conversion. The child is not a small adult. He's small in everything. So physiology, anatomy, pharmacology, everything is different. So the hepatic biotransformation is immature, as we mentioned in physiology. The hepatic enzymes are underdeveloped. The protein binding to the drugs is quite different. Muscle mass is different. Fat store is different. Glucose is different. Everything is different in children. It's just not. If you get a child 20 kg and if you get a child or age 40 kg and you might find another adult or 50 kg, they are not close to each other. So the child is going to have a surgery shortly. What are you going to do for that? You need to go down to assess the child if there is any illness and severity, pre-operative assessment. You find any problem early to detect it. You would like to optimize the patient quite early. And all of this, why you do all of that? You need to improve the outcome, okay? And I told you I was involved in the development of the pre-operative assessment clinic in my hospital. So you wanted to do pre-operative evaluation for the children like exactly the adult. We do that for the adult, and we don't have children, a big section of the children. We try to do that for children as well. The upper respiratory tract infection predisposed to coughing, laryngospasm, bronchospasm, desaturation during anesthesia. They come to you, the child has a mild cough. Yeah, it's mild cough. But this mild cough for me under anesthesia is a major factor. Snoring and noisy breathing due to adenoid or tonsillar hypertrophy lead to airway obstruction. Chronic cough due to subglottic stenosis or previous tracheoesophageal fistula repair is very important. Check if the child has productive cough, might be bronchitis or pneumonia. Sudden onset cough like foreign body or aspiration, and we talk about loose teeth, and you know those days, sorry, the children play with electronics a lot. If the patient has a stridor due to macroglossia or laryngeal wave or laryngomalacia, if the patient has hoarseness of voice due to laryngitis or vocal cord palsy or papilledema. Check if the patient has asthma, how controlled, if he's on bronchodilator, did he have any previous hospital admission? Why like that question? Because it shows you that the asthma is severe. And if the patient has bronchodilator, did he have his bronchodilator today? And we need to give it just before coming to the anesthesia. Does the patient had repeated pneumonia? Might be due to immune deficiency. History of foreign body aspiration is very important, not only for the respiratory system, but it gives you indication that the child is a child for special need or underdeveloped cerebral or neuro system. Very good to know the record of the patient. That the patient has previous anesthesia And if it's anesthetic in the same hospital, you might go to check the chart of the anesthetic. If there is any problem happened before, you might be aware about that. And as well, when we report the anesthetic record, we write that in full detail, because as well it is a medical legal issue. So we write the size of the cannula, the way the patient induced is inhalational induction or IV induction, the size of the endotracheal tube, the size of the mask we use, amount of the fluid, antibiotics, if the patient is allergic to anything like that. All of these are extremely important. If the patient has congenital syndrome or congenital heart disease, if any environmental issue or immunization and the vaccination are very important for us to know. So despite we said all of that, we don't recommend or we do not ask for routine investigation for children, because by virtue, they are normal. And we don't ask for anything unless there is any indication for that. Very important to keep your children fasting and to know the protocol of fasting. 6 hours for solid food and 4 hours for semi-solid like formula milk, 2 hours for clear water. There is increase in nausea and vomiting in increased fasting. It is not good to keep the child fasting for 12 hours from 9 o'clock in the evening, and the patient will have surgery by lunchtime next morning. It will be another higher incidence of nausea and vomiting for those children, and the child will be dehydrated, of course. The child, of course, is anxious, and his family is anxious because he's crying, he's hungry, thirsty, and sorry for that. And they need something to relax the child. So sometimes we go for that, but sometimes we don't, because sedation, my apology. Sedation may be for hyperactive children, may delay the recovery and delay the discharge from the hospital. But another medication which is very good, like EMDA cream, to minimize the pain for the cannula. Sometimes you give them chlorohydrate, 50 milligram per kilogram body weight. Sometimes you give them ketamine or clonidine or narcotic if required. So ketamine is very important and is very safe in the children, especially in rural area. It is oral. I never give it oral, but it is recorded to be given oral, 6 to 10 milligram per kg, and IM muscular between 3 to 4 milligram per kilogram, and IV to 2 milligram per kilogram body weight, but is not as pre-medication. That is for induction doses. Sorry, those ketamine here is induction, not as pre-medication. But the most common one for pre-medication is midazolam, 0.5 milligram per kilogram oral, and ask the mom or the dad to put it, or the nurse to put it in orange juice or even clear water, and the child can swallow it. Sometime before the patient coming to the operating room, I give them some fentanyl, nasal fentanyl, 1 microgram per kilogram body weight, because the nasal mucosa is a very good surface for absorption, and the children got very good sedation with the nasal fentanyl. Now, the patient is coming for the operation, basically, for example, tonsillectomy. Which way should we use? We did the pre-operative visit. We come to check the equipment in the operating room. We check our drugs, prepare our drugs, prepare the anesthesia checklist and the surgery checklist, and we concentrate about the post-operative routine stuff. So pediatric operating room setup is one of the highest tension in the operating theater. We get the pediatric emergency thoroughly checked every morning. We get the pediatric thoroughly checked, and warm the operating room for the children, as we mentioned before, especially if the preterm or neonate, warming light or active heating. Prepare the operating table, we have the mattress, which is warm enough, warming blanket, forced air, pediatric warm mattress, pediatric shoulder roll, head, every single stuff we check by 2 people to be sure that everything is prepared before the child comes to the operating room. We don't forget that to turn the monitor to pediatric mode if or unit accordingly to the child coming. Set up the pediatric monitor, ECG, blood pressure, pulse oximetry are usual. If the patient needs arterial line or central line, we usually insert them accordingly. We know the pulse oximeter, the all claim or respiratory distress came down because the pulse oximeter is in action. And enter the monitor on the ventilator, enter the right weight and age for the working station. Prepare the pediatric appropriate breathing circuit accordingly. The patient about coming to the operating room, I go back to ask to discuss with the dad and the mom about the anesthesia induction, and even with the child himself. I give him a sample for the breathing circuit. I will show it to you in 2 seconds. And I tell him that you will have the mask if the patient is going to have inhalation induction. Sometimes we keep their toys with them to feel very safe. I'm sorry. I adopted that from one of the hospital. That's a checklist we go through, and the ventilator is functioning, face mask is available, oxygen supply is available. All the checklist should be done before the child come to the operating room and sign. Another emergency drugs prepared, and the monitor and the emergency equipment are available. Different range of pediatric anesthetic equipment, monitor devices, and disposable items should be available. Airway management equipment like face mask, tracheal tube, laryngeal mask, oral airway, different sizes should be available. Pulse oximeter with pediatric probe should be available. End-tidal carbon dioxide monitoring, ECG, pediatric blood pressure, all of them are coming small to match the children age and size. Cannula for the children sometimes go between 25, 24, 22, and here when we go increase the number, decrease the diameter. So usually 22 or 24 are very small, and they can be suitable for children. If the operation goes beyond 30 minutes, or we have to measure the temperature, and oral suspension drugs and equipment, including defibrillator, should be available around the operating room. Anesthetic machine, incorporate ventilator that permit use of the pressure control ventilation, and the beam for the size of the children should be checked and signed. So factor affecting, are we doing good with the time now? Factor influencing the choice of the anesthetic technique. How old the child? Does the child understand the cannula? Can he tolerate the pain for the cannula? Did we put EMLA cream on the hand? Or we're going to go for the mask induction? What is the underlying illness? Does the patient have any congenital anomaly, any respiratory problem, any cerebral palsy, any special need? Is the child cooperative? Does the child have autism? Is the child hyperactive? Some stage like that, we have to give the children pre-medication, as we mentioned before. Will the parent be available around the child? Does the patient have an IV cannula or not? And what are the skills of the anesthesiologist? So basically, in this situation, we need more than one hand to help. Myself, when I am in my theater and I have young doctor with me, I have this performer. For every single child in the list, in my list, I do that. I ask him to put the age and weight, what cannula you are going to use, what is IV fluid, not IVF like children reproduction. It is IV fluids, laryngeal mask sizes, what is the endotracheal tube, how much paracetamol will you give to that child, and the blood loss expected for that operation, the date of birth of the child, the weight, as we mentioned, how much fentanyl will you give to the child, if you give morphine, how much morphine, atropine, how much atropine, propofol, sodium thiobentone, intraval, how much muscle relaxant will you give to the child. It's very funny because we know that atropine dose, for example, is 15 microgram per kilogram body weight. In the operating room, we get the atropine diluted to 100 microgram per ml, or whatever you want to do. But I usually do it 100 microgram per ml. And when I ask my young colleague, how much, if this patient goes to bradycardia, how much atropine will you give him? Usually his reply is very clever, 15 microgram per kilogram body weight or 20 microgram per kilogram body weight. No, it's not the answer like that. You prepare the atropine in the syringe and you put it standby. If the patient, if this child has bradycardia or any incident, you need to give him atropine. How much volume of this syringe will you give him? 150 microgram, it means that 1.5 mil. 300 microgram, it means that 3 mil. So you should understand, what should I give for that child with me? He is the only child I have today. Every child in the operating room is the only child I have every day. So even I have 10 children in the list, every child of them, I deal with him as he's the only child I have in the operating room. Again, that is a performer from Massachusetts. Sorry for that. And they usually go take pediatric card, warm the operating room, prepare the OR table, change the monitor, set up the pediatric monitor, all what we said before, and they do it. Prepare the pediatric IV set. Usually I have burette, and you know, I use it all the time, and it is filling in 100 ml fluid to avoid any overloading the children. So we're coming to be serious a little bit more. We have seen the child in the outside or in the ward. We talk to the mom and talk to the dad and talk to the child himself about induction of anesthesia, and we talk to them about what's going to go. If the child needs blood transfusion, we ask them permission, and consent, and we talk to them about the induction of anesthesia, and we talk to them about the pain management. And even, you will be surprised, here in my hospital, if we plan to give the child like paracetamol and diclofenac PR, I have to ask the consent, and I have to write that in the chart that I asked them a consent for bare rectal medication like paracetamol and diclofenac for analgesia. So we are coming for induction of anesthesia. There is two ways we use for induction of anesthesia. Inhalation induction, which in the last 20 years, there is 4 issues. It changed our behavior in the operating room. Number 1, sevoflurane. Number 2, fentanyl. Number 3, laryngeal mask. And number 4, remifentanil. And propofol, sorry. So those 4 agents, it changed our behavior in the operating room. For example, inhalation induction, it was with ether is never good, and then moved to hallucine. Hallucine was attractive for inhalation induction, but it is highly toxic because it's very, very sensitive to the myocardium. It makes the patient bradycardia in no time. So now it is replaced widely and universally by sevoflurane. Sevoflurane is an inhalational induction agent and inhalational agent, anesthetic agent, and it changed our behavior in the anesthetic room completely now. So inhalation induction could be an excellent for children that fear of the needle and has difficult venous access. However, it needs another skilled person with you to do the IV line immediately after the patient is asleep. Correct size of the oropharyngeal airway may be required, and choose one that the same length as that from the corner of the mouth to the angle of the jaw. And that is the breathing circuit, which is the Jackson-Rees modification of the Mabelson that suits children. It is a very low resistance because it's open from here. It doesn't cause any problem with the child. The fresh gas flow coming from this way, so to the mask, we should have a filter here. And that one goes to the child exhale going here, and by the time goes here and can drain air from the environment. So the oxygen is continuously coming here. Oxygen is coming with inhalational agent to make the child sleep, and that valve is open to prevent rebreathing and accumulation of carbon dioxide. And that is the environment here. The child is very happy, and the nurse showing him his toys, and his mom is wearing the PPE, and the doctor is just waiting for him here, and the nurse is sitting beside him, and basically they are going to take him to the mask. Again, you see that's a simulation of the pediatric anesthesia, and it is widely recognized training tools, the simulation now, before passing those or before sitting to the program. IV induction. We have mainly around 2 or 3 agents for IV induction. Number one, ketamine. We talked about that before. For pre-medication, and we have sodium thiopental, which is intraval. You know that very well in the clinical practice. You always give him intravala. Intravala means that sodium thiopental or intraval. Propofol. Propofol is not widely used in pediatric, especially in young age, especially if you give it propofol infusion, because propofol is claimed for metabolic acidosis, hemodynamic instability, hepatomegaly, rhabdomyolysis, and multiple organ failure, and hyperlipidemia, because propofol is mainly done from lipid. Despite all of that, we're still using it for children. We give them a small dose, once only is fine, but we don't run it for infusion because there is a syndrome called green urine syndrome, and this is not good for children, especially metabolic acidosis. But ketamine is very safe, and interval is very safe as well, provided you give it strictly intravenous with appropriate dose. For IV induction, you have to have IV line. Basically, IV induction needs IV line. And usually in the back of the hand, the child comes with 2 Imla cream on both hands, or the inner wrist. You have to know the anatomy now very well, where you get the vein. Loads of technology now coming to show you the vein and infrared and all stuff. But basically, once you did the IV line, you have to fix it very well. Otherwise, you will lose it with any small movement of the children. Use elastoplast or anything like that, or wrap the vein very well to fix it. Intravenous induction can be taken with propofol or thiopental or ketamine. You need to do pre-oxygenation very well for the children. And we know from the physiology, they have very small functional residual capacity. They can run to hypoxemia very quickly. It is nearly an hour now. Am I too long for you? It just nearly finished. So the intubation for the children, we did the induction. A straight megal blade, and we show it now, are useful in neonates and infants. Usually we start from size 0, the best for 4 kg. For young age group, we use non-cuffed tube. A small leak is very important because the lower mean arterial blood pressure means that you cannot inflate the cuff, and the mucosal perfusion will be very low, and those children you compromise the mucosal lining of the trachea. How to know prepare? You know the performa I did before, I showed before. We put it like what you do exactly in the emergency department. The ambulance call you. We have a child. He's 5 years old. What's his weight like? You put that in the board, and you start to calculate what tube are going to use that. The tube size here is age divided by 4 plus 4.5. Usually, or age divided by 4 or plus 4 up to 10 years. The tube length is very important. As we mentioned before, the trachea is very short, and if you push the tube far in or take it out superficially, it's very dangerous. So you have to listen to bilaterally, and you have to fix the tube at appropriate length. And this is the size of the tube here, and usually when you intubate, you have to see the tip of that black side outside the vocal cord. So that black lens should be far beyond the vocal cord. And this type here is the tube. You see how small the tube in comparison to the adult size of the tube. Basically, the size of the tube is written outside in one figure, and the length of the tube is written on the other side. And again, that's type of cuffed, non-cuffed tube. That's cuffed tube. Basically, if you have 5.5 non-cuffed tube, it's equal to 5 cuffed tube. Why the size of the tube is very important? Because you know the flow of air is very dependent on the diameter of the tube. So another point of the children, because the airway is narrow, so the resistance to ventilate is high. So that's why you have to choose the appropriate size tube, not to underventilate those children, not to overventilate, not to make a high pressure on the mucosa. There's a lot of certain issues around that you have to put in your mind when you come to the ventilation. As we mentioned, less than 8 years old, we use non-cuffed tube with allowed leak a little bit. Above 10 years old, we use cuffed tube. Sometime in emergency situation like appendix or septic abdomen or whatever, I use the cuffed tube, but I don't inflate the cuff because the cuff is like 0.5 size in the tube. So the 5.5 non-cuffed tube equal to 5 cuffed tube. And this is a special type of the tube, which is called preformed tube or ray tube. That usually we use it in tonsillectomy, adenoidectomy, or facial operation, or neuro operation. That is a tube, and you fix that to the jaw. That's how to choose the size of the tube. And this is the Miller or the laryngoscopy here. And this is the difference between Macintosh and the Miller laryngoscope. Miller laryngoscope are usually flat and longer a little bit, and this one, Macintosh, is curved. Why that one is advantage in the children? Because as we mentioned before, the epiglottis is long and funnel shaped, so you need something to raise the epiglottis to avoid obstruction with the intubation. Different issue with the general anesthetic. We sometimes we don't go with the tube, we go with the laryngeal mask, and we have here different sizes of types of laryngeal mask and different sizes. This is the smallest size, size 1, around 5 kg, and we inflate the cuff of the laryngeal mask with 4 ml. And we put that preforma in the wall in the operating room for teaching and for nursing to know exactly how much you put in the laryngeal mask to avoid leak or to avoid overpressure on the mucosa of the children. And this is a special type of laryngeal mask. It's called iGel. I use it a lot in adult. I don't use it in children much because it's very stiff and it is not popular in children. However, it is used, but I go with the conventional nasal mask in children. But for adult, I use this one a lot. And the same again. So maintenance of anesthesia, usually between oxygen, air, nitrous oxide, some people are still using nitrous, and the volatile agent. Propofol for children, younger children, less than 10 years old, we don't give it as infusion, but we should be cautious as regard nausea and vomiting. We give them ondansetron and dexamethasone. Operation usually require antibiotics. It's very important to check if the child is allergic to any antibiotics or anybody of the family. Sometimes this is anesthetic for the children is the first time. So you should be asking the family, do they have any allergic reaction to any drugs or any, because sometimes those are genetics. Very important here, the fluid therapy. The goal of fluid therapy is, number one, to replace the deficit. The child is fasting. His mom is very good and keeping the child fasting from 9 o'clock last night, and he is coming for operation around 10 in the morning or 12 in the lunchtime. So almost 10 to 12 hour fasting. That child could be dehydrated. So you wanted to replace the deficit of the fluid. Maintenance of the fluid, that child needs around 40 ml. If he is more than 10 kg, he needs 40 ml per hour. And there is a certain stress loss for trauma for the surgery. It depends on the surgical operation itself. And if any bleeding, need to replace the bleeding. Usually we start with a bolus of 10 ml per kg as a bolus to replace what the child deficit, and avoid glucose containing fluids unless the patient is hypoglycemia. Be cautious that operation needs analgesia, and usually we use a multimodal analgesia. Pain management is very essential. Multimodal approach. You use local anesthetic in the wound, use paracetamol and or non-steroidal anti-inflammatory or ibuprofen post-operatively. You have to know the doses of those drugs very carefully. If you use opioid, it's not ideal because it results in post-operative nausea and vomiting. But if you have to use it, you have to use it and use the appropriate doses and between intramuscular, intravenous, and oral opioid. Local anesthetic is magic if you can use it. Sometimes if the child is asleep, you can give them the epidural. Some people give the caudal analgesia. Is the operation in the around the pelvis, so they give them caudal block. Nausea and vomiting, number one, hydration. Number two, pain control. Number three, different antiemetic like Zofran, and ondansetron, or dexamethasone or cyclizine. Common post-operative problem in pediatric, you have to be aware during after anesthesia, especially like delirium is very important. After 2 weeks, the mom and dad come to you, I don't feel my child is the same since he had the anesthetic. And typically, yes, we blame the anesthetist. He's the reason for that. And we don't know because they have lots of factors, not like the adult. Usually we have complication like what I told you about our airway obstruction today with me in the morning, and they have laryngospasm, post-operative croups, they have bronchospasm, sometimes they vomit and aspiration. Take home message today from my lecture, please. Pre-operative assessment and preparation is extremely important for proper outcome. Treat the child with respect to his identity. Be empathetic and professional to the child. Be extremely punctual. Calculate your doses accurately. All drugs should be calculated very accurately. It doesn't matter how big the child or how small. Sometimes you give 12 ml or 12 milligram of whatever drug, but you can't give 15. You have to go to 12. Induction and the emergence of anesthesia are extremely important time and the most vulnerable time for complication. communicate properly and appropriately and timely manner with the nursing staff, with the dad and mom. If any problem happen, you have to brief the people correspondent. You have to talk to them very professionally, to explain to them very honestly. It's beyond the scope of this lecture today, but it's very important as well. And thank you very much again for inviting me to do this lecture. And I'm so proud to be before you here. Thank you.